The topic for today is mechanical thrombectomy, an overview. I am Dr. Pratik Kishore, fellow under Alurkar sir, and Karaburkar sir will be chairing the session. So stroke is the leading cause of morbidity and one of the leading cause of mortality. In US data, it ranks 6 in the leading cause of mortality. So a paradigm shift of stroke management happened in the year 1996 when IV alteplase was taken into consideration for a window period stroke. Next, in 1998, the catheter-based intervention came when PROACT trial was passed on. 2004 witnessed the early stent retrievers technique, the Mercy techniques. And in 2008, we saw the window being extended, the IV TPA window being extended from 3 hours to 4.5 hours. Subsequently, in 2015, we saw the glory of all these trials, where all these trials established mechanical thrombectomy or embolectomy as a gold standard of care for a patient, correct patient in window period. In 2018, again, the window period had been extended from 6 hours by diffuse trial to 16 hours and by Dawn trial to 24 hours when a perfusion-based imagings have been selected for a certain patient. Also in this years, we saw the patient with last seen normal. Like we don't have that. When was the patient last seen normal? We had this diffusion flare with mismatch. If no one has seen the patient, the MRI witnesses the patient, and if the witness has that diffusion flare mismatch, we can take them from thrombolysis, or we can take them for mechanical thrombectomy if the large vessel occlusion is seen. Coming to 2015, all these trials done in various parts of the world, Netherlands, Canada, Australia, USA, Spanish, all under different ethnicity of population, showed glorious results and great results in getting TK2B or 2C or 2-3 or 3 grade scales, and eventually establish mechanical thrombectomy as a standard of care. So when we see a recanalization rate, the trial was successful. Also in MRS scale, this trial outcome, everything. Then ICH was almost comparatively, there was no difference between the control sum, and also the device has mild complications, mild like embolectomy, perforations, ischemia, and ICH, and also has a mortality benefit. So considering all these factors, now ASA has included level 1A evidence of mechanical thrombectomy in large vessel occlusions with number needed to treat as low as 1.8 to 2, which is the best amongst all the interventions done on human body. So this will be the outline of presentation today. We'll see basic history, and we'll see the materials overview, then stent retriever, the main armor which does the thrombectomy work, and the techniques of clot retrieval, then comparative analysis between all the techniques, and we'll go on quickly to the cases. So history: in 1983, Zoomer et al. Were the first to perform basilar thrombolysis via catheter injections of streptokinase in 5 patients, and they had an exceptional outcome. So on that basis, PROACT trial was conducted. It was an RCT that recruited around 180 patients, and it was on the catheter-based interventions. The microcatheter was inserted, and 9 milligram of RTP or pro-urokinase was given to the patients, and the control had heparin. So out of 180 patients, there was a recanalization rate of 66% and a hemorrhage rate of 10%. However, the trial didn't got an FDA approval for that. Then the evolution of these stent retrievers came. It was 2004 that marked the Mercy retriever, and then 2009 the Penumbra system, then 2010 the distal access catheter for the better support, and 2012 and 2013 witnessed stent retriever Solambora technique and ADAPT techniques. We'll see all this one by one. So the first stent retriever or the coil retrievers were the Mercy retrievers. Now these devices were mechanical embolus removal in cerebral ischemia retrievers, was the first device approved for recanalization treatment in acute ischemic stroke in 2004. The device were of 3 types. This is the X variant. It has a coiling tip. It is approved for embolectomy. This is the L series, where there is a non-tapering tip and has a coil around that. And this is approved for foreign body removal. And this is the hybrid version incorporating a non-tapering tip with a coil. So this was the Mercy coil retrievers. That was the first generation device. Second came the Penumbra system. Penumbra system, we saw it came in 2008. So what is this? This is the aspiration catheter, and this is the separator. How does it work? The aspiration catheter is taken as near to the clot as possible, and then the separator comes out from the aspiration catheter and macerates the clot. When the clot is macerated enough, the separator goes inside and clot is sucked in through this aspiration catheter. If after repeated episodes of aspiration fails, then a stent retriever is taken off and the clot is retrieved through the stent retriever. So this is the Penumbra technique. But we saw out of all these glorious trials, there were certain trials that failed when compared to the RTPA combination. So why these trials failed? IMS3 synthesis, Mr. Rescue didn't have a positive results on the impact on patient because they didn't use a proper stent retriever, and also CT angiogram was not taken into consideration by all these trials. So these trials didn't show a positive result as compared to the other 5 trials that showed benefit result in 2015. So these trials almost established the superiority of stent retrievers over the non-stent retriever techniques. Now, before going to the stent retrievers, we'll see the materials, what basic materials we require. So this is just a snapshot. This is the long sheath. Into this long sheath, this is the aspiration catheter, and into this aspiration catheter is the micro catheter over a micro wire. So we make an access here. 8F femoral short sheath is inserted, and then diagnostic catheter inserted through a long sheath through a coaxial technique, and diagnostic angiograms are taken. Now we have to remember while doing a mechanical thrombectomy, we have to see ipsilateral side, contralateral side, and also a posterior circulation to check for collaterals if the time permits. Then the diagnostic catheter is taken out, and into this long sheath, aspiration catheter is inserted. Now, irrigations has to be connected to all the tubings to prevent any stasis. Then these long sheath and aspiration catheters are parked in the petrous ICA segment. When the long sheath goes up to the petrous ICA, it works as a balloon guide catheter and prevents a distal like the proximal. It prevents the proximal arrest. Then through this aspiration catheters, the microcatheters is passed through a micro wire. Then the micro wire is taken up to the clot intima and passed. After passing the micro wire is exchanged and the stent retriever is passed through the microcatheter. Now, a few things we need to remember. When the stent retriever is passed through this hub, we need to hold the hub in opposition so that the stent retriever doesn't get entangled into this hub. Second thing is, when we open the stent retriever through this unsheathing technique, the whole system has to be pulled back. Third thing is, when the clot, we need to engage the clot such that the stent retrievers engages the proximal 1/3 of the clot, and distal 2/3 of the stent retriever should be free. Then the whole system has to move back as a whole system. When the clot is entangled in the stent retriever, we don't feel a backflow proper, and we feel a little resistance while taking back the whole system. So it indicates that the stent retriever is engaged with the clot. Now, when the stent retriever is being taken out from the clot to the aspiration catheter, this is the point where stent retrievers may get blocked. So it is wise to remove this Y connector and take the stent retriever out directly from this catheter. And before going for the second pass, we can aspirate the aspiration catheter and the long sheath so that there is no thrombus or clot entangled on these long tubes. So this is just the mechanism of stent retriever technique. What instruments we use? The guide wire is the basic scaffold. We have the hydrophilic wires and the hydrophobic wires. Basically, Teflon and silicones are the component that makes the wire hydrophobic. These hydrophobic wires have a very good high torque controls. So Amplat's wire or the Lundquist wire or the Benston wire are the hydrophobic wires. And hydrophilic wires, these are hydrophilic wires, 035 system, the basic glide wire, which the most of the interventions works are done. The advantage of this is it provides minimal friction. Coming to the long sheath, after the insertion of short sheath, we have this long sheath that needs to be inserted into the short femoral sheath. The basic concept is that when we are as near to the pathology as possible, the control of the microcatheter and the micro wires are the best. So coming to the first guide catheter, this is the Envoy. It is based on steel platform. The steel platforms, the advantage of steel platform being it doesn't break, but it has the property of having it doesn't have a kink resistant. It doesn't have a shape memory effect. So it has Envoy has a two zone. It has a very good pushability. Whatever force we transmit, it is transmitted to the catheter, but trackability is poor in view of it is non-nitinol based. So now this is the Envoy catheter. We can safely park into a Petrus ICA. Then this is the Neuron Max. The Max is for long sheath and Neuron is for distal access catheter. So long sheath again can be passed. It is based again on a steel platform. It can be parked in Petrus ICA. This catheter is based on the braiding platform of steel, and proximal part is little stiff for pushability. The middle part is little less stiffer because to improve the trackability, and the distal part is traumatic little soft, but it can go up till the Petrus ICM. And then this is Cerebus and Bellas and various other long sheets can be used according to the requirement. Ballast particularly is very common in radial interventions. Now, over the long sheath and aspiration catheter, we have a microcatheter. Microcatheters, there are two systems, O21 system and O027 systems. This is for large vessel occlusion. We go to 017 system for medium vessel occlusions, and the wires are 014 wires, most commonly Striker and Traxxas wire and Ashai wire we use. So any of the microcatheter can be used. They work on the same platform. They are braided, and the braiding decreases distally, and so that the pushability, trackability, and also these have probability of durometer. Durometer means we can shape of the microcatheter with steam shape, and it retains its shape because the nitinol is present at the outer end. So these are the platforms. In a difficult access, we need a triaxial system. Maybe a distal access catheter may be required. Distal access catheter works on the same braiding platform of steel or nitinol based on the catheter which we use. If it is Navion, it is entirely nitinol. If it is CAT5, it is nitinol plus cobalt. If it is Neuron, it is based on steel platform only. Again, on the same platform is the aspiration catheter. The aspiration catheter and the distal access catheter are nearly on the same platform. The difference is in the size. The aspiration catheter is large, the bore is large because it needs to entangle the clot. And also when we do an aspiration, the force can be transmitted if the bore is large size, and it is longer because it has to go more distally. So A68, Sophia plus Cat6, React, these are most common aspiration catheters that we use. Also, we need to it has a sleeve inside. The sleeve inside is important, that it incorporates the stent retriever inside the distal end. Sophia Plus has a demerit that doesn't have a sleeve, so it often has a demerit that it may break when the stent retrievers are taken in. So having seen the basic material, we'll come to the main armor, the stent retrievers. So why the stent retrievers? Why they have a special property? Because it is made up of, all the stent retrievers are made up of nitinol. So what is nitinol? Nickel, titanium, and novel ordnance laboratory. So it is modified and produced in that. It has a property of super elasticity. What is super elasticity? Means it can return to the original shape when the stress is removed. So it has a shape memory effect. So when we see this graph, stress and strain graph, at the minimal diameter, it produces a minimal force, outside force. Then as the diameter, as the stent is being unsheathed, it produces a regular resistive force. And at the extreme, when the stent is completely resheathed, it has a chronic outward force. With this chronic outward force, it engages the arteries, and it is able to engage the clot. So this is the property of nitinol that makes it as a very good stent retriever material, because of the shape memory effect and the chronic outward force it produces on the arterial wall. So what is the basic requirement of stent retriever? It should have a radial force. So radial force we saw because of the chronic outward force. It should engage the clot whenever it is. It has the ability to be resheathed. Because sometimes we go multiple passes, 2 or 3 passes, so it can be resheathed in and out. And then it should have a minimization of endoluminal damage. So the Stent retrievers basically were serendipity. It was initially designed for as a aneurysm bridge therapy. So the solitaire AB, the aneurysm bridge, AB stands for solid aneurysm bridging, and then it was changed to solitaire FR, the flow restoration. So it was basically a serendipity when the aneurysm treatment was when the aneurysm assisted coiling was done. So it was seen that the Stent retrievers engages the thrombus very well. So this came as a serendipity. So what is the mechanism of recanalization of stent retriever? It entraps. So it entraps the clot which is lying in the large vessels, and there is a mechanical disruption. So when a stent retriever is open up, the struts, the vertices of the stent retrievers will disrupt the clot, and also it will improve the blood flow towards the clogged segment. So what will happen? The plasmin naturally will go towards the clotted segment, and it will produce a chemical or endogenous thrombolysis. So entrapment, mechanical disruption, and chemical or endogenous thrombolysis are the basic mechanism that through which the stent retrievers work. So we have myriads of stent retrievers, the basic materials being same, the nitinol, all have a shape memory effect and all can be resheathed. Major fabrication methods of stent retrievers are laser cut, but however, there are braided stents currently in the market that say that the endoluminal damage in the braided stents are less when compared to the laser cut stents. New studies are coming up. So basic stent retriever, solitaire, one of the most common stent retriever, Trevo, ticket retriever, embotrap devices. So coming to solitaire, it is nitinol base as laser cut, parametric design, closed cell design to engage the clot with peak-to-peak connections. The stents are available in 3, 4, and 6 diameters, depending on the vessel wall which we are working on. And the stents have additional platinum markers. Platinum markers are here at the proximal and distal ends, and the markers are spaced at 5 to 10 mm ends to just for the visualization of stent opening and clot integration. The Trevo, same platform, nitinol laser cut. It is also a closer cell design, and again platinum and tungstens are added. So this also has a coating of sodium hyaluronate. This is meant to reduce the friction during the stent deployment. And also these sizes are again 3, 4, 4, and 6 in various sizes depending on the vessels which we are working to. Then this is the embotrap device. If we have a look, this is the closed cells inside and the open cells outside. The closed cell is meant for increasing the radial resistive force to engage the clot, and open cell is to engage the clot. Also, distally, it becomes a closed cell design so that it works as an embolic protection device at the distal end to engage the clot which is being embolized. 3D vascularization devices, also one of the stent retriever. It is unique binary nitinol based laser cut open cell surface which has 4 inner chambers, and these 4 inner chambers and outer chambers. So outer chambers are basically to engage the wall, and inner chambers are to engage the clots. Just work on the same platform, nitinol laser cut. It is also laser cut with an open cell design. So comparative analysis between the first generation and the third generation. The third generation devices all score overs all these parameters. Successful recanalization is better in third generation. Favorable clinical outcome is better in third generation. Rate of ICH is also less, and groin puncture time is also shorter in the third generation devices. So what is the basic technique of stent retriever? The technique of stent retriever delivery first requires blindly crossing the occlusion with a microwire microcatheter combination. A microcatheter angiogram is necessary to ensure correct intraluminal position. The microwire is exchanged for a stent retriever that is then deployed across the thrombus by pulling back the microcatheter like a sleeve. So standard unsheathing technique is pulling the system back and unsheath the stent retriever. But in Trevo, they say that pushing in the stent retriever into the clot during the deployment, the push and fluff technique scores over standard unsheathing techniques. And this is especially for Trevo design. They have made that PFE technique is better than SUT technique, the standard unsheathing techniques. Also, longer the stent retriever, the better is the radial force and better is the clot entrapment, and so better is the outcomes while dealing with any arterial occlusions. The stent retrievers are deployed for a few minutes, usually 5 minutes. It is for solitaire, it is written 2 minutes, and for Trevo, it is written 5 to 7 minutes. It's called incubation period, so that it is the time required for the struts to engage the clots. So after this, the clot can be taken out as a system. So this is just a comparative analysis for Trevo, the push and fluff technique and standard unsheathing technique. They found it that PFT was better than SUT in Trevo stent retriever with a higher recanalization rate. Now, techniques of clot retrieval. After the basic of stent retriever, we have stent retriever with balloon guide catheter, with distal access catheter, Solombra technique, adapt, and other techniques. We'll go one by one. So this stent retrieval technique we have already seen. Penumbra we have discussed. The fast and adapt we'll see now. Solombra is a combination of solitaire and aspiration catheter. Protect is again a modification including a balloon guide catheter, aspiration catheter, and stent retriever. And there is a distal embolization protection also technique that we'll see. So adapt technique. What is adapt technique? Adapt is a simple modification of penumbra technique in that a large aspiration or reperfusion catheter is taken. So this is the clot, this is microvire, this is microcatheter, and this is the reperfusion catheter. So reperfusion catheter is taken to the extent of the clot, to the proximal end of the clot, and the advantage is that it is a large catheter, so that the a radial force that is transmitted is much more, and aspiration force is also very good. So, and the clot is sucked out into the aspiration catheter. So there are two mechanisms. One is the clot gets disrupted and is sucked out, or the whole clot can be sucked out and the whole clot gets corked in the distal end of the aspiration catheter. This is the Solombra technique. When we compare, this is simple aspiration penumbra, this simple stent retriever technique, and this is the combination when we have a stent retriever plus we have a aspiration catheter. So it is solitaire plus penumbra, Solombra technique. So after that also, there was various modification of Solombra technique that has happened. But why? The basic mechanism being there is a tendency for the clot to dislodge at the distal end when the stent retriever is being pulled out. So what happens? Initial activation of the retraction of all forces applied to the proximal aspect of the embolus, relying solely on the adhesion of the embolus to resist fractures of the clot. As the device clot ensemble turns around the tip of ICA, clot can be snowplowed into ACA, causing distal emboli to a new territory. Mobilization of the device through the tortuous path of the ICA, and in particular the carotid siphon, can lead to rapid acceleration of the device despite constant and gentle retraction by the operator, and leading to loss of clot fragments from the device. The most important cause of clot fragmentation is the eventual entrance into receiving catheters, where clots corked at the end of the aspiration catheter are caught in the cells of stent retriever and can be sheared off by the receiving conduit. So these are the mechanisms where the clots can be dislodged while the stent retriever is pulled into the aspiration catheters. So various techniques have come. This is called the protect technique, where the proximal flow arrest has been made to the balloon guide catheter. So it is a proximal balloon occlusion together with a direct thrombus aspiration during stent retriever thrombectomy. So it is a modified Solombra technique, and various studies have shown that when the BGC balloon guide catheter is used, the MRS and also the TICI recanalization rate has improved when the proximal flow arrest is done. So what is the mechanism? When we see this is the clot. This is the collateral pressure that is acting on the clot that is acting on the opposite direction. And this is the antegrade pressure that is acting. And this is the systemic pressure. So in total, when we see a clot, these two are opposing the clot retrieval, and these two are favoring the clot retrieval. But when we do when we use a balloon guide catheter, it will cause a flow arrest, so that the systemic pressure that is opposing the clot retrieval will be cut off. So only collateral pressure, it will be an antegrade, the P antegrade pressure minus the collateral pressure. So balloon guide catheter work on these vector mechanisms. Various modification of techniques. Solombra we have already seen. This is stent retriever, aspiration catheter, guide catheter. So the stent retriever is being taken to the aspiration catheter, and the suction is applied at the aspiration end. There is no suction at the guide catheter end, so the antegrade flow of blood happens. So there is an antegrade flow in AC and antegrade flow in MCA. So this can, because the antegrade flow is still happening when the stent retriever is being retrieved into, so the embolus can dislodge from this and can cause distal occlusions. So modification of this technique came the arts. It is merely like protect technique only. So again, the same stent retriever, aspiration catheter, guide catheter. Now they have used a balloon guide catheter. So this causes the proximal flow arrest. The proximal flow arrest happens. It is just like protect technique. The proximal flow arrest happens, but when the stent retrieval is taken at the aspiration catheter mouth, there is a retrograde flow that will still happen because there's retrograde flow in the AC and the antegrade flow in the MC that will still happen because the full arrest has not has happened. So modification to this technique came the safe technique. So what is this technique? This is the double aspiration technique. So we have to aspirate at the aspiration catheter and we have to aspirate at the guide catheter level. So aspiration at the guide catheter level will lead to resultant vectors at retrogradely at the clot orifice. So now what will happen? These vectors, these are like it will pull the clot inside. So this is the double aspiration method where the flow of the blood is also retrogradely. It is going towards the guide catheter, it is going towards the aspiration catheter. So this is the safe technique. So modification of Solumbra just to minimize the clot dislodgement during the procedures. Now this is the Lazarus effect. This is the distal embolization protection device for stent retriever thrombectomy. It consists of funnel-shaped nitinol base designed to surround the stent retriever and the enmeshed thrombus during retrieval. So this is the device. It's a funnel-shaped device. Following stent retrieval deployment, the Lazarus device is positioned at its proximal end. So Lazarus at its proximal end. Retraction of the stent retriever against the device cause it to invert and roll over the outside like a stent retriever. It's just roll over outside the stent retrievers. So it covers the basically clot and prevents a distal dislodgement of the clot. So it has also used with distal aspiration techniques. Now, having seen the basic techniques, we'll just see through what are the various modifications and various access we can make. So we know MCA is an offshoot of ACS. ACS is the first artery that is formed in the cerebral circulation. So MCA is an offshoot. Now MCA can have bifurcation, trifurcations. This is the anatomical M1, and when the superior division or the inferior division is in line with the anatomical M1, we can still consider this as a M1 and it's called a clinical M1. So this is the clinical M1, and we can access through the same mechanism because it is in line, and we can take out the clot through Solumbra technique. So what is mostly seen is the inferior division is more in line with the MCA. So this study shows that the M2, the inferior division of the M2 is more in line with the MCA, and so the first pass effect is more in when the clot is there in the inferior division of MCA. So it is an anatomical versus clinical M1. Size of stent retrieval depends on which level of occlusion this study has studied the major large well occlusion, predominantly M1 occlusion. So they have seen that 4 mm size has the highest rate of first part effect. However, the longer the stent retriever, we know the longer is the radial force, the longer is the clot entrapment property. But this study shows that 4 into 40 mm size has the maximum FPE when used in IC occlusions. Now, when there is a clot which is very refractory, so we need to engage the clot such that the radial force is so much, the entrapment we need, that entrapment of the clot is adequate so that the suction force is prominent on that. So in this, we can use a double stent retriever techniques, predominantly at the bifurcation end. So it provides a good radial force, it provides a good engagement, and also with these two stent retrievers, the clot can be aspirated easily. So this is a dual stent retriever technique predominantly for a bifurcation clots. So now always the question comes, shall we use aspiration or shall we use a syringe? So all these comparative studies analysis have shown if we use 50 ml or 60 ml syringe, that is almost nearly equivalent to the pump in terms of flow rate and aspiration force. The force is adequately transmitted even if the syringe pump is used and the syringe size is large. So larger the syringe size, the larger is the force that is exerted on the aspiration catheter or the guide catheter, whichever we are applying the pressure to. So just the comparative analysis, these were the trials that compared the ADAPT technique versus the stent retriever technique. So both Aster and Compass, when compared head to head, they almost led to the same conclusion that ADAPT and stent retriever, whether it is aspiration or whether it is stent retriever technique, they are nearly equivalent They are nearly equivalent without any significant changes in between the two. So we can use any of the technique depending on the vessel is occluded and what is the mechanism of ischemia. Okay, in a comparative analysis between these two. So now we are moving on to the medial vessel occlusion. In the posterior circulation, particularly in the P2, P3 domain, when we saw the first pass aspiration was the first pass stent retriever. The aspiration technique scored over a stent retriever technique. It is just a study that has shown that in the MIVO, the aspiration technique has scored over the stent retriever technique. However, whichever technique we are using, it predominantly depends on the mechanism of ischemia, what is the nature of the clot, and what has happened exactly that has caused the ischemic damage. So when we have situations, when we have an ICAD and in situ thrombus, we have to do an intracranial stenting as a rescue treatment, because despite repeated passes, these methods will fail and in situ thrombus is very common. So placement of intracranial stent is a bailout maneuver in cases of persistent occlusion despite repeated attempts at mechanical thrombectomy. This strategy makes sense considering that intracranial atherosclerotic stenosis accounts for around 10 to 30% of acute ischemic stroke. This data is from Asian population, not from Western population. So it is very high. The ICAD is very high in Indo-Chinese population. And many ruptured atherosclerotic plaque would not be expected to necessarily recanalize with thrombectomy. So intracranial stenting can be done as a bailout maneuver. Having seen all these methods and all, we'll move on to the cases. So first, when the stroke protocols is activated, what happens? What is the stroke protocol exactly? So we can do a CT-based protocol or MRI-based protocol. CT-based protocol is to rule out hemorrhage and do an aspect score, and further moving on. When we have an MR-based protocol, so what are the sequences that is required? We have a flare sequence. This is a diffusion sequence, SWI, and this is a top sequence. When the window period is beyond 6 hours, we do a perfusion sequence. So this is top. What we see exactly in this first sequence, we see a cutoff, the MCA cutoff, the left MCA cutoff after the M1. What we see in this flare, there is no changes, parenchymal change in the flare, but we see a little hyperintensity. These are hyperintense cortical veins that are prominent because of ischemia. What we see at the diffusion, this is the diffusion changes that has happened in this territory. It is very important to do an SWI. If we don't do a CT, we have to do an SWI to rule out hemorrhage. And at the SWI, what we see is the blooming thing. What is this blooming thing? It is the RBC rich clot that is blooming. Next, at this ganglionic level cuts, what we see is the cortical veins hyperintense. Why these veins are hyperintense? Because of the ischemia. There's a deoxyhemoglobin accumulating, and any deoxyhemoglobin accumulating has a RBC rich tendency and it will have a blooming effect. So same thing. Next, we need to do a perfusion scan if the patient comes out of the 6 hours window. So this is the perfusion scan, time to peak, mean transit time, cerebral blood flow, and cerebral blood volume. So what we see, we have a separate scale for all these. So these are different sequences. When the time to peak is high, the mean transit time is high, and cerebral blood volume is low. So we have a fair degree of ischemic penumbra, and the patient can be taken for mechanical thrombectomy. Again, the mechanism of ischemia is very important while dealing with. So when we have an MRI that shows a cutoff and we have a blooming, what we get is the red clot. The red clot is the RBC rich clot. The stent retriever can fully open because there's not much resistance to it. It is made predominantly cardiogenic or a source from a large vessel. It can be easily extracted and has a blooming effect. Contrary to that, what we have, when there is no blooming in SWI, this is the fibrin-rich clot what we have. So the stent retriever will not open fully because it will not exert a proper radial force because of the fibrin. It is seen in ICADs, and it is very difficult to extract. Predominantly, we need multiple passes, and after multiple passes, there is less recanalization property, and there won't be any blooming. Now, this is again before going to the cases proper. This is the clot meniscus sign. What exactly it is? It is the meniscoid appearance of these arteries. When we see the outer scaffold of the arteries are sealed, it indicates And this is also the same. It indicates that the clot is little permeable, so that contrast can permeate through this. So whenever we see these signs, we see that the clot is little fragile, it is RBC rich, and the contrast can permeate through this. So clot meniscus sign is a good prognostic factor, and we can take out the clot because it is predominantly an RBC rich clot, and the contrast can permeate through it. So having seen this, all this background, we'll come to cases one by one. So first case, 60-year-old male presented within 5 hours. So he's out of the IVT period with sudden onset left hemiplegia and slurring of speech. Left hemiplegia and slurring of speech, the localization is right hemisphere and the artery is right MCA. So no IVT was given and it was directly shifted to the cath lab. So we'll see the images. So it is CT scan was done. CT scan was done to rule out bleed. Then the CT scan based aspect scoring is done. So aspect scoring is done at ganglionic level. This is the ganglionic level, and this is the supraganglionic level. At the ganglionic level, we see caudate not involved. We see globus pallidal not involved, lentiform, and we see the posterior limb of intercapsule being not involved. So it is only the insula that is involved. Again, M1, M2, M3s are uninvolved. And at the supraganglionic, M4, M5, M6 are uninvolved. So the aspect, CT aspect is 9. There is no bleed. We have ruled out bleed. And also what we see is a hyperdense MCA sign. When there is an RBC rich clot, the Hounsfield increases, the Hounsfield number of increases, and it appears as a hyperdense MCA. It is also again a good prognostic factor, and it is an RBC rich clot. So we do an MR just to see where exactly is the cutoff, so that the right MCA is cut off. Now, patient has been taken for a mechanical thrombectomy. Right MCA hairway C is cut off. Post stent retriever, there is a complete recanalization. Coming to the next case, a 72-year-old presented within 3 hours. So it is well within the IVT period with sudden onset giddiness and dysarthria. So giddiness comes predominantly from the posterior circulation. When giddiness and dysarthria is there, the localization predominantly in the posterior circulation, and he has all the risk factors: diabetes, hypertension, ischemic heart disease. So within the window period, IV tenecteplase was given and patient was shifted to cath lab. So what we see here, we see a basilar cutoff. Basilar cutoff, we see it is maybe a clot meniscus sign is predominant here. So first pass, TK3 in the first pass. So all these are important prognostic factors. IV tenecteplase was given to this patient, and also with the first pass, the patient attended TK3 recanalization. 50 years old female, coming to the third case, presented within 2.5 hours with sudden onset right hemiparesis and aphasia. Right hemiparesis localized to left hemisphere, and artery is left MCA. Aphasia means the proximal stump, either it is M1, is occluded. And so patient comes with within the window period of IVT. So IVT is given and patient shifted to the cath lab. So here we have a hyperdense MCA sign. And when we see at the CT aspect score, caudate looks clear, the internal capsule looks clear. There is a doubt in the globus pallidus, lentiform nucleus, and also in the insular lesion. So maybe 1 or 2, and here also in the M5 distribution. So CT aspect is around 9 with a hyperdense MCA left side. What we see in MR, there is a total cutoff of left ICA, no ICA is seen, only ECA is filling through top angio. So there is a total cutoff. So right ACA is the ACA supplying, the right ACA supplying both the sides, and the left MCA totally cut off and left ICA is totally cut off. So when we do DSA, we see a flame shift. Normally we see flame shift because the contrast is permeating through this. It can be seen in dissection, it can be seen in proximal occlusion, it can be seen in stenosis also. And so it just indicates that there is a thrombus which can permeate the clot. So it's called peak sign, flame signs also. So this is the carotid stump. The balloon plasty is done. This is the balloon at this position. And then the antegrade flow is established. So we see the carotid siphon being established. However, we don't see any MC and AC being recanalized. So guide catheter is taken, aspiration catheter is taken. Along with that, aspiration is done, and we establish a TK2B recanalization. So this is the case of proximal with distal occlusion. Now coming to the fifth case, 70-year-old male presented within 10 hours. So this is 10 hours. It is out of the window period of IVT. And we have to do a perfusion scan because I out of the window period of EVT. So perfusion scan is must in this case. Presented with right lower limb weakness. So it is predominantly a lower limb weakness, means predominantly a paracentral lobule area may be affected and slurring of speech. CT brain was done that showed no bleed. So we'll shift to MRI and we'll shift to MR perfusion scan. So this is the MRI. What it shows a left ACA infarct. So what exactly artery can we prescribe aspect to it? Aspect scores are not meant for ACA, so we cannot prescribe an aspect score to it. But however, we are seeing flare changes in this territory, the paracentral lobule, predominantly parasagittal area being involved. It is the humeral artery, predominantly a middle lenticular striate artery, that is involved in this territory. So presented with opposite side, lower limb weakness, slurring of speech. So we do TOF sequence and we see a cutoff. We see a cutoff here. This is the left A2 cutoff in this territory. Then in order to do a middle vessel thrombectomy, we have to do a perfusion scan, but the perfusion scan shows already established clot. There's no mismatch, so patient was managed conservatively with DAPTs. Coming to the next case, 50-year-old female presented within 3.5 hours with sudden onset right side weakness and dysarthria. So localization is left hemisphere and the artery is left MCA. She's a known case of RSD on acetrom and had defaulted a drug for 1 week. It was a puja, so she has defaulted the drug. So on examination, there was right human facial palsy and right hemiplegia. So complete hemiplegia was present on the right side. The INR was subtherapeutic, but it was less than 1.7, so can be taken up in the IVT window. So less than 3.5 hours with subtherapeutic INR can be taken for IVT window. Also can be taken for mechanical thrombectomy if there is a large vessel occlusion. Let's see what she has. So this is the CT aspect. What we see here is a dot sign. So it indicates, it is same like the Hausfield number of these areas have increased. So it indicates that the occlusion is predominantly distal. So distal occlusion is there and the dot sign is present and aspect is fairly good. So we don't see much of the territory being involved. But when we do an MRI angio, what exactly we see, the MCA is filling on this side, but the MCA, there is abrupt cutoff in this MCA territory. So where exactly it is in the inferior division, the clot thrombus is lying in the inferior division of the MCA. So left inferior division MCA, so only IVT was given. Only IVT was preferred in this case because it was non-eloquent cortex and the patient was also not so affording to go into the distal occlusion in the M2 territory. Next case, 60-year-old man presented with left hemiparesis and slurred speech since 5 years. Power in the left upper limb was 0/5 and left lower limb was 1/5. So weakness on the left side. So localization is right MCA territory and the patient came out of the IVT period. What we see, this is a DWI sequence. We see the chordate being involved, the lentiform nucleus being involved. Also, we see the insular peninsular area being involved. So it is the aspect, the MRI aspect, which generally overestimates the aspect score, is 6. The MRI aspect is 6, can be taken up for mechanical thrombectomy if it is a large vessel occlusion. So what we see here, there is a total right ICA occlusion. We don't see a right ICA being formed in this TOF sequences. This is the PCA, not to be confused with right MCA. This is right ICA is not formed here. So again, the same picture, we have very thinned out right ICA, but here we see through the collaterals ophthalmic being formed. So the little EC-ICA collaterals that is forming the ophthalmic, the right ICA is seen, and this is the ECA. So what is done? Balloon is taken, balloon angioplasty is done at the level of right ICA. What we get a little antegrade flow. So antegrade flow is established, this territory. Then after the antegrade flow is established, microcatheter is over the microwire is taken and microcatheter injection is taken. What we see here is the microcatheter injection and what we see here is the clot lying inside. So we have a tandem occlusion where ICA and both MC are affected. This is a lenticular striate vessels seen in this. So microcatheter injection showed clot. So the stent retriever was open. And after the first pass, we got a TK2B recanalization. So we were successful in taking out the clot. However, when the sheath was taken outside, so there was a tendency to recanalize. There was a tendency to recanalize again. So a rescue stenting was done with C-guard. The C-guard has a mesh that prevents the distal embolus. So C-guard stenting was done, and patient was loaded with aspirin, Brilinta, and overlapped with tirofiban infusion for next 3 to 4 hours, and CT was done after 6 hours. We were lucky enough because this patient was not given IVT because the patient presented 5 hours after the period. So it was after the window period of IVT. So aspirin, Brilinta was safely given, and stenting was also done in the acute setting. Next, 77-year-old man presented with sudden onset right hemiparesis 5 hours after the onset. He has a past episode of TIAs and known case of diabetes hypertension. When a patient has repeated episodes of TIA, we should suspect any large vessels or any ICAD because the same territory is being affected, and also he has risk factors, vascular risk factors that can lead to vasculopathy. So what we see here a acute left MCA cutoff. So right hemiparesis with a left MCA cutoff. So what we do, going step by step, each step, this H1 catheter, we see an arc. The arc is little difficult, type 2 arc, difficult to cannulate, almost 2-3 passes were required, and catheter was repeatedly falling. However, somehow we reached the area. Then we saw only the inferior division of MCA was filling. The superior division, if we notice here, the superior division of MCA is not filling, and there is a slight stenosis on this area. So next we have crossed the wire over these areas, and the stent retriever. The stent retriever put into the superior division of MCA. After the first pass, what we see the superior division being little opened up. However, we see the narrowing indicating that the clot is still persistent, and there's a cutoff through this. Then the second pass was done. After the second pass, what we saw, the superior division opens up, but there's a snow plowing. What has happened? The clot has migrated from the superior division to the inferior division. Next, the stent retriever was taken again in the inferior division, and again it was retracted, and inferior division recanalized completely. However, the superior divisions again had the stenosis, and there was a tendency to recanalize. So it was decided to put balloon expandable stent cruise was put in this patient, and rescue stenting was done. And what we achieve is the TK 3 recanalization after 3 passes. Next patient, 70-year-old man, presented within 30 minutes. So he presented very early to the hospital with aphasia and right hemiplegia. So aphasia, right hemiplegia localizes on left MCA territory. IVT was withheld because outside they went to the local hospital and it was given, heparin was given. So we didn't directly taken up for MRI. So diffusion also, the changes in diffusion also has not started. Also, the flare is completely free. So patient was shifted to the cath lab. What we saw here is a flame shed IC occlusion. So this normally we see in dissection. Again, what it indicates, it is called a peak sign or a beak sign. It indicates that there is the clot is fragile, and it has the contrast has a tendency to move forward. So putting the guide catheter, aspiration was done. Post aspiration, there was recanalization, and the IC was seen forming. Now the wire was crossed across that, and macrocatheter over the wire has been crossed across that. So a macrocatheter injection was again taken. We see the MCA being formed. Then stent retriever was taken because the clot was seen, and stent retriever was taken into the catheter, and we achieve a TK 3 recanalization. So earlier the patient presents, the better is the recanalization. So he achieved a TK 3 recanalization in the first pass only, despite having a tandem occlusion. Next patient, 51-year-old man, presented with sudden onset left hemiplegia. The symptoms were 1.5 hours from the onset of symptoms, had fever preceding the symptoms. He was RAT positive. So this was during the COVID time. Patient had COVID and presented when into the window period. He didn't take the COVID vaccine, so he was affected with COVID. He had strong pulmonary symptoms. So IV tenecteplase was given and then directly was shifted to the cath lab. So what we see here a ICA thrombus. So when we look at the extent of the diagnostic catheter, when we look at the extent of the thrombus, we see the whole ICA is almost filled with the thrombus. So the clot burden is very, very high in this case. So this is the COVID catastrophe. Diagnostic was changed with guide, exchange with guide, and then aspiration was done. So with aspiration, there was mild distal recanalization. However, we can see thrombus overlying full ICA. So it is completely filling the full ICA. When we when we took a head shoot, there was no, it is only ICA. There was no collaterals that is serving the ophthalmic arteries. It's only ICA, and the total ICA occlusion was there. So it was decided, because of the high thrombus load, it was decided to take a balloon guide catheter to because there's a huge clot burden and the clot will have a tendency to migrate. So we'll do a proximal flow arrest. So balloon guide catheter was taken. Then microcatheter over the catheter was and microcatheter shoot was taken. What we see here is again an MCA cutoff here with a huge clot burden. Then stent retriever aspiration technique was taken. We took 3 to 4 passes, and we got a TK2B recanalization. However, the prognosis was not so good in this patient. So because of COVID, he had a very high clot burden, and we have to do repeated aspirations and repeated passes to take out the clot. Next patient, 65-year-old man, presented with sudden onset right hemiplegia and aphasia, 2 hours from the onset, well within the IVT period, known case of diabetes and hypertension, with repeated left MCTI over last 2 weeks. Again, an indication that this is a large vessel occlusion. And IVT tenecteplase was given and was directly shifted to cath lab. So what we saw in that MRI, if we carefully look, there is a left ICA cutoff from here. And this is the MIP images. MIP images at the carotid canal segment, we see a right ICA here, but we don't see a left ICA here. So this is left ICA is cut off from almost from the origin. Same here. And we're not very sure whether it is a thrombus sitting over here or just a vein that is very prominent here. So what we see in the DSA, so left ICA is completely cut off. There is no flame peak or beak sign. So it is just the hum, and the ICA is cut off. But when we take a head shoot, what we see, there is a EC-IC collateral and ophthalmic artery being reformed through ECS. So with this cutoff, when there's a cutoff, we have done a balloon plasty. Balloon plasty leads to opening of the carotid and forward flow is seen, but subsequently recanalization after 2 attempts of balloon plasty happens. So it was decided to immediately stent the carotids to gain an access. So we have done a rescue stenting. Carotid artery stenting was done after loading with antiplatelets. And what we see after going upwards, what we see is a MCI is filling properly. So TK2B recanalization was done. Here we don't see a prominence of ACA, but in the opposite, in the right ICA shoot, the ACA is well filling both the sides. So we are rest assured that we have achieved our target. And one ACA serving both the sides. Coming to the next case, the last case, a 68-year-old presented with sudden onset left hemiparesis and dysarthria, 4 hours from the onset of symptoms. Pulse was 80 per minute, BP was 170/90. BP was a little on a higher side. Within 4 hours, so well within the IVT period, so IVT was given. TPA was given, tenecteplase was not given because tenecteplase is approved for 3 hours only, and patient is shifted to cath lab. So after IVT, patient is shifted to cath lab. What we see, right ICA is clear. There's no problem. We make an access through guide catheter. What we see here is an MCA cutoff. Again, the MCA is fully cut off from here. So microwire, microcatheter injections shoot, and then followed by stent retriever. The stent retriever, these are the, I think this is a Trevo stent retriever what we have taken. So stent retriever is passed on, and what we achieved is a TK2B recanalization. But after this, we see a sudden shoot of BP. So what exactly had happened? We were not very sure. We did a CT and we saw hemorrhage. So it is probably a reperfusion bleed because contrast extravasation was not seen during the check images. So reperfusion bleed has happened within 30 minutes of the procedures, and patient eventually had to undergo decompression surgery because the reperfusion bleed was causing enough mass effect. So after we saw all these thrombectomy procedures, even all the mechanical thrombectomies, we can have some complications like the reperfusion bleed or the wire perforations or dissections of the artery, which we are working on. or failed passes can happen. Or even after establishing a TK2B or 2 or 3 recanalization, patient will not have a very good prognosis because the time elapsed would have happened and the cell necrosis would have happened. So we need to choose the patient correctly, which one patient to work on, and other parameters are also has to be kept in mind. Summarizing all these, mechanical thrombectomy has revolutionized stroke management, and anatomical boundaries of thrombectomy are becoming bigger, and medium vessels are being approached now. Mechanism of stroke, whether it is embolic, whether it is in situ thrombus, or it is ICAD, or it is a perforator ischemia, or it is a lacunar infarct, should be kept in mind while doing any interventional technique. The vascular risk factors are very important. What is the baseline NIHS of the patient? What is the collateral of the patient? How is the first pass effect? And what is the availability of stroke ICU? That are the major factors that that indicates the that prognosticate the prognosis of the patient. Thank you.
Your extensive coverage to the subject. I have a question.
Yes, sir.
When you take your micro catheter,
Yes, sir.
or whatever 27 or 21,
yes, sir.
You take it through the one where you are going to aspirate, or do you take it separately when you do the Solupra?
Sir, we normally do what we have done, sir, like majorly aspirate through aspiration catheters and or the guide catheter when we are taking the guide catheter also, sir. So we do double aspiration techniques, sir. Micro catheter aspirations we have not done, sir. Also, literature wise, sir, when the bore of the catheter is very small, the force effectively cannot be transmitted. So,
I'm not saying that you aspirate. What I'm saying is, when you are doing the Solumbra technique,
yes, sir.
You take the micro catheter and you take the aspiration catheter.
Yes, sir.
You showed some cases.
Yes,
I
sir.
was not clear whether your stent retriever catheter goes through the aspiration catheter or it goes through the balloon guide catheter or the guide catheter, whichever guide catheter you take.
Sir, when we are doing Solumbra, we'll take the stent retriever through the aspiration catheter, sir.
No, I don't think that is a good idea, because if you take it through the aspiration catheter,
yes,
you are reducing the available space for the aspiration.
Okay, sir.
So I don't think that is a good idea. I think the microcatheter should go separately, not through the guiding catheter, not through the aspiration catheter, because then you will get the double force.
Okay.
And the full force of the guiding catheter of the aspiration catheter will be used to aspirate the clot.
Okay.
At least that is what we do. We always take them separately.
Okay.
So if we have we almost always use a 9F balloon guide catheter. We don't rely on the neuron max getting wedged in the pictus ICA.
Okay, sir.
We always use a balloon guide catheter.
Okay.
And when we disconnect, you showed it also, but we are very particular about that. So when we disconnect the stent from the Y,
yes, sir,
we aspirate strongly on whatever the guide catheter or the balloon catheter that you have, that is long sheet. So either whether it's a balloon guide catheter or whether it is the neuron max. So when we aspirate strongly, in fact, we find a lot of stuff in that balloon guide catheter and less in the stent.
Okay.
So those are the two suggestions that I would have.
Okay.
Otherwise, your talk has been very exhaustive. You have covered everything very nicely.
Okay.
Very good.
Thank you, sir.
Any questions or any comments now? Jayshankar there?
Sir, I'm here, sir.
Yeah. Any Yeah, tell
Sir,
me.
you are mentioning about, sir, O27 alone or O21 also. We want to take it, sir.
Whichever one you take, if you
Okay.
take to your aspiration catheter, what is the idea of catheter? It is 0 or 7.2 or 6.8, depending on which one you are using. The maximum is 7.1, 6.8. So
Yes,
you
sir.
are reducing that much, the 6.8, you reduce it by O2. What is the ID? What is the OD of that? I don't know what the OD is. But you are reducing that much space, no? So the
Yes, sir.
aspiration will not work.
Mm,
It will not be as efficient. You already have a bit. I don't understand what the problem is. Because you have a
Okay.
neuron, or you have a balloon guide catheter. Neuron max, through the neuron max, you can take both. You can take the aspiration catheter and use a 9F. If you use a 9F balloon guide catheter, 8F both won't go. But through a 9F both will go. So we always use a 9F. And I think even through a neuron max, you should be able to take both separately, not one inside the other.
Okay, sir.
Any questions, any comments? Okay. Then I think we'll end this session. It has been a rather long one, and Pratik has done a good job. Thank you, Pratik.
Thank you, sir.
Thank you, sir.
Yeah. So let's see what we have next week now.